This Wednesday morning, my son passed. So
I heard from Kevin on Tuesday afternoon, and you told me that he had been rushed to the hospital, had what they thought was a seizure, and
ended up
that was kind of the start of it.
Yeah, the seizure caused a cardiac arrest.
We wanted to talk about, would you call it complicated alcohol withdrawal?
It doesn't have to be complicated, just about alcohol withdrawal in general, right? And it's one of the key concepts that's covered in any kind of addiction medicine program, right? Sometimes they'll lump it together with alcohol use and sometimes alcohol withdrawal. And you had a case that was horribly sad and upsetting, and unfortunately it parallels what we've heard from different patients at different points. We've heard people that are scared to stop drinking, because they're worried about having a seizure.
Yes.
And we've also heard from parents that stop cold turkey, then we're scared they're going to have a seizure. And
Yes.
why didn't you tell us, right? And we've all had patients that have had seizures, right, where they're doing what's in their best interest. And I've had another case where, fortunately, the person didn't pass away, but they ended up in the ICU for several weeks, where the patient and their mother decided, okay, it's time to stop drinking. They just didn't know.
Right.
They just had no idea about how dangerous it was medically.
Right. And in my work, I lately, not lately, but all the time, but more recently working in a withdrawal management site, I see a lot of people with alcohol, and we always have to sort of guide that. We're kind of a quasi-medical model. Sometimes we have a prescriber on site, sometimes we don't. Sometimes we have a nurse, sometimes we don't. But even in these events, like where do we get to, so if we have somebody that has a history of a seizure, and we determine a history of seizure is someone's had a seizure in the last 2 years. If they've had a seizure in the last 2 years, then we make them go to hospital first and get medical clearance. So that's the process that we follow in our site. But the 2 years, that's an arbitrary time. And so it is something we're very fearful of, right? Especially when we have individuals that are, have a long history of alcohol use and no history of sobriety periods.
Yeah, and you've hit the nail on the head there, right? Where this is potentially very, very dangerous, and everyone's doing their best to try to figure it out. And what's very clear is that, I don't know if it's in the last century, the last however long, people have known that alcohol withdrawal is a medical emergency. Up until a couple of years ago, all of the detoxes in Ontario were 100% non-medical. All this stuff is really a 3 to 4 year initiative. Maybe got amped up during a COVID, so I'm not so sure. And historically, I think these detoxes were under the regulation of the Liquor Control Board or something like that. There's something weird where the police used to have these drunk tanks. They'd hold people overnight, then they ended up transitioning them there. But the whole idea that you have a provincial organizations that are designed to detox primarily from alcohol. They have no medical support whatsoever, although it's changed in the last 2-3 years. And alcohol withdrawal is a very, very clear medical emergency. And historically, in all of the addiction medicine talks, and even internal medicine talks, they would say, opiate withdrawal, you feel like you're going to die, and alcohol withdrawal, you can die from.
Right. And so it's a good shift.
It's a very, very good shift. And it's very well done, because it's one of those things where how many beds are there in the province? 100,000? I don't know, 500 total in the province. How do you make all those beds medical, right? And then the standards for hospital-based care is so high. So what they're doing is phenomenal, right? Because some of these places now have 9 to 5 RNs that are there. They have certain screening tools. They have pathways of going back and forth. And even when I started visiting the detox here and there, maybe a couple of years before you did, all of the workers there can sort of tell when someone's been well covered. If they send somebody down to the emerge and the person's gotten 20 milligrams of diazepam, 3 doses, okay, at least they're not going to seize on me immediately, right? And they can tell when they send somebody in, they get sent back with nothing. The person can't walk and they're shaky. They're like, I think I'm going to have to send them back. And so these people that work in these detoxes, historically have been quite good at figuring out when someone has to go back and when someone doesn't. They can't always tell the physician in the hospital what to do, right? Being different sites and all that.
Absolutely. Yeah. No, it's always a delicate dance as to what that medical clearance looks like, and whether we, sometimes we get, a lot of pressure points from different providers, different partners in the community when we push back for medical clearance, because there's like, oh, he's not going to go, and then so he's not going to get any care at all. So do you really feel like you're really putting this barrier of care by not accepting this person? I'm like, I see how you see it like that, and I understand that, but we're only trying to keep people alive, right? That's our only goal in asking for medical clearance and getting a physician to clear this person. And medical clearance is kind of code for something a little bit different, which is like, can you send this guy with the proper medication? It's not really said like that, but that's really what it is, right? In a lot of cases, if this person needs medication, can you please provide it? It's called medical clearance. Like but that's kind of the underlying ask.
Yeah, because when someone comes to a detox, it's not in the first 10 minutes there that you need them to be comfortable. It's over the next couple of days,
yes,
right? And the situation can change dramatically for it. And in my mind, some of the thought that I thought would be worth covering, in addition to the clip and the idea, right? Because it's such a sad story, but it's so real, right? And these, I'm assuming they're a family that has financial means, right?
Yes.
If they wanted to, they could have gone to wherever to do this. The things I was thinking would be worth covering, I mean, other than the video and whatever comes out of that conversation, because it's quite an interesting video. There's a few layers to it. Is what would make somebody at risk for having those withdrawal symptoms? What symptoms would they see and when?
Yes.
And what can you offer medically or otherwise to help support people during that period? And it might not come up today, right? But if it does come up, I think it's also helpful to know where they can go potentially, right? Like, where do you go do this? Do you do this at home? Do you do it otherwise? And we have a very different climate in Ontario where I think for us, we see the gaps. We don't see what's happened that's completely different than what's available in other places and other areas. And so there may be value about talking about the model that they're using here.
So let's maybe have a look at them. So what we've done is we've pulled three clips together here. They're relatively short, and they're full warning. They're kind of hard to watch.
Very hard to watch.
This is a gentleman that's lost his only child, I have not personally been blessed with children, but I can't even imagine what that would be like. And this is he's speaking on his podcast. This is literally, I think, like 3 or 4 days, 2 or 3 days after his son passed away. So it's tough to watch. So here we go.
This Wednesday morning, my son passed. So
I heard from Kevin on Tuesday afternoon, and you told me that T had been rushed to the hospital, had what they thought was a seizure, and
ended up
that
being
was kind of the start of it.
Yeah, the seizure caused a cardiac arrest. He was basically dead in his room on the floor with EMT working on him. And they got him back and got him in the ambulance. And tried to save his life.
Yeah, what a clip and what a story, and it makes me almost feel completely insensitive for being so formulaic around the stuff that I wanted to cover today, because I would never hear someone's story of a bad outcome and then saying, "Hey, this can be done differently," because we all do our best in all of these situations, right? And we do our best as a human being, as a friend, as a father, as a healthcare provider, and sometimes these adverse outcomes happen, and it's a very different process to work through with a family member, what could have been done differently. And I know for myself, when I've had bad outcomes that happen in the context of a seizure or withdrawal or whatever that might be, and then I end up meeting with family members later, I don't go through with them what could have been done differently and when, but I do reflect on myself. Are there certain things we could have offered earlier, certain things we could have done differently? What could we have done to have prevented that outcome?
Yeah, and I think he's speaking of this to bring awareness to it. So we're not trying to be, kind of armchair quarterbacking the situation on him. Yeah. He's trying to if you watch the totality of his content, he is very much Tristan is the name of his son that passed away, the 26-year-old son.
Oh my God, he's so young.
And he was instrumental in starting. The son was instrumental in getting the father, who's a celebrity, an actor, a world famous wrestler for many decades, onto this podcast. So it was very important to him, Kevin, the father, to bring awareness to this subject, and he thought his son would want this to be spoken about, and that was kind of his motivation behind it. So I'm with you there. I don't want to, God forbid we would be saying, oh, you should have done this or you should have done that. That's not where we're coming from. And but let's see if there's some kernels of knowledge that can be learned from this.
And the thing is, even when you were talking about your screening criteria, right? So say if somebody calls coming into Detox, you have a couple of questions you ask. And for you, what makes someone high risk of a seizure? You said 2 years, some kind of a seizure, right? And maybe that's it. But when I'm seeing somebody individually, I mean, obviously on the checklist, if you've had a previous alcohol withdrawal seizure, you're more at risk to have one again.
Yeah, for sure. But that's a ridiculous standard, because so if you use that standard, which, not to say our policy is ridiculous, but there should be other standards as well, because the gentleman that we supported, recently had, been drinking for 40 years and had never had a sobriety period.
Absolutely.
We were talking about that before we started recording. And, I mean, clearly that gentleman, is to me is much higher risk than the person that hasn't had a seizure 22 months ago.
Yeah. And it's tough because you as an individual, right, can just tell. You hear the history, you're like, okay, this is a red flag. Sometimes what we do as people or healthcare providers, we follow the protocol, right? We have a checklist because they try to standardize the approach for everyone.
Yes.
And so in medicine now, there is a scale. It's called the Predictor of Alcohol Withdrawal Severity Scale. It was developed by Maldonado in California. And they have two screening questions plus a few other questions afterwards. But usually you have to have the person in front of you to go through it. And for me, clinically, like if I have someone who's daily drinking more than 8 standard drinks per day, and it's been several weeks, they're going to be at risk of having withdrawal symptoms. That's the way that I see it. And the longer that you've been drinking, and then the other factors like old age, previous withdrawal symptoms, medical comorbidities, drinking hard liquor, non-palatables, you're going to be at higher risk for those withdrawal seizures. And so when I'm seeing somebody, I try to get that narrative of what they're using. I try to create a space where they can actually share with me what they're using, because sometimes people don't feel comfortable. Oh, just a couple of beers, a couple of this. Then you have to ask, like, how big is the glass? How many bottles are you going through a week? How many times do you pick up a 2-4? Do you drink it all on your own? Do you drink it separately? Do you find you get shakes and sweats in the morning? Do you have that morning anxiety? Like, after you drink that morning anxiety, you have to have an eye opener in the morning. How do you get through the day? There's certain over-the-counter things that work on similar receptors. There's certain medications people take that work on similar receptors. And so there's all these things that suggest the person could be at risk of having it. And historically in the emergency department, so even if they had gone earlier, if the person's not having withdrawal symptoms there, it's currently not standard of the care for the emergency doctor to figure out what are your symptoms going to be like over the next 3-4 days.
Yes, it's very complicated, because it's not, we can make a lot of decisions about, whether you should, but we're also trying to keep someone in care. So it's much better. We have to kind of make a lot of judgment calls, whether, okay, if we can tell, or our staff, as you mentioned earlier, are very experienced at seeing, okay, this guy, he needs to go back to the hospital, right? So
well, you see that. Once you get a gut feeling, you have that heuristic to sort of say, hey, is this guy comfortable or not?
Right. And is this guy look like the folks that we have supported that have had seizures, right?
Yeah.
So you know that look, right? And I'm like, and even they. So and there's an autonomy issue too, because no, I'm not going to the hospital. I'm fine.
Yeah, they might leave. They might leave before they follow your recommendation.
Right, and I'm like, and so it's that time I got to say, oh brother, I know you feel okay, and I know it's going to be a pain in the ass, and I know the hospitals aren't that great, and I even work in one. I know that, but I've seen this look too many times, and then they say, well, yeah, I mean, I did actually have a seizure like 6 months ago, and I didn't tell you when I was coming in.
Yeah.
Okay, no problem. That's okay. That's not a problem, but we don't want you to have the seizure again. We want to get you comfortable and make this, good detox for you. And you really got to get down, not down at their level, but you got to speak at their level and kind of sometimes win them over, because you don't have control over these situations. You actually have to, you have to get buy-in. Right?
Yeah, absolutely. You have to get buy-in from the person to go, and then you have to get buy-in from the medical team to provide proper medications, and it's just a complicated picture all around. And so the amount people are drinking, the daily nature of it, the non-specific withdrawal symptoms during the day increase that risk. There's that PAWSS scale that's there as well, and then the other thing that people don't always think about: if you reduce dramatically what you're drinking, you can be at risk too. So say if you've been drinking quite regularly, right, and you get to the point that you're having, like, say, a Mickey of hard liquor a day, or a 12-pack, or a 2-4 a day, and you half it all of a sudden for a week, you're also at risk of a seizure. So even if you have a little bit of alcohol, but it's less than what you usually have and you've been having for a while, that can also put you at risk of having withdrawal symptoms and a seizure.
Well, that's a really interesting point, and I knew about the withdrawal symptoms from reducing. I did not know. So if I'm going from 2 Mickeys a day to 1 Mickey a day, I could still get a seizure as well.
Yeah, if there's certain vulnerabilities in you in some kind of way. Yeah, absolutely, it is possible. And so sometimes you will have people come in that actually have an alcohol level and they've already had a seizure. Right. The other thing is that not everybody has symptoms. Right. So I literally, like, this is within the last couple of weeks, we had a guy that had a seizure. He had a couple more in hospital, and it was really around, like, there was no real symptoms. And it was only weeks later that we sort of figured out that, I'm changing some of the information around it, but it was a while later that we did figure out he was drinking maybe about a third of a 2.6 a day. He was on benzodiazepines as well. But in the narrative and in the hospital, he wasn't actually having clear withdrawal symptoms. So he wasn't really scoring on the CIWA, but he's having these seizures. So is it that he has some other vulnerability, but the narrative of the drinking matches the seizure too, right? But he's not having sweats, not having shakes, blood pressure, pulse is fine. And so not everybody is built the same.
Yep. Okay. So let's get to the next clip.
Maybe just one other thing, right, that I think is incredibly important. And this is one that I wouldn't mind putting a figure up if it's okay. I'll send it to
100%.
you. It's a Maldonado's figure around the timeline of alcohol withdrawal symptoms. And it may be linked to what's coming up there, although I'm not talking at all about the heart attack. So whether it's stopping drinking completely, right, or whether it's drinking a dramatically less amount, right? So you go from a 2.6 a day to like a couple of shots a day. In the first 2 to 8 hours, that's where you get sweats, a little bit of shakes, a little bit of what other symptoms with elevated pulse, anxiety, that kind of stuff. From the 28 to 48 hours, that's usually when you're at that high risk of having a seizure of some kind.
Okay.
And then on this Maldonado figure, usually about like 1 day to about 3 days, 4 days, they talk about the hallucinosis that you sometimes get. Although it's controversial, some people say it lasts a little bit longer, and sometimes you get cases where it's a little bit different. 3 to 7 days is where you get the thing called the DTs. Delirium tremens, right? And that's when people can see things, they can hear things, they get completely confused, the autonomic system changes dramatically. And then there's this longer withdrawal that people can have sometimes till 13, 14 days, right? Not always, right? And so, and because you have a seizure or because you have the DTs, it doesn't mean like you're more at risk for the other. You can have one without the other. You can have them both together. Sometimes the CIWA score brings it up. It's the phenomenology of alcohol withdrawal is a bit complicated. It can take many, many different forms. And what happened in this case was also a little bit rare, right? So this person probably had some kind of heart thing where the seizure triggered a heart attack. right? So it wasn't just the seizure; it was a secondary medical thing because of it, right? And I think it's so complicated and nuanced.
Yes.
And I just thought I would just like it's hard for medical people to think about the full pathway. It's not fair for a person to figure it out on their own, just in the general public.
Right. And the one thing that we don't know about this is that, so Tristan had in 2022, he was hospitalized for 60 days with an alcohol-related situation. So that's all we know about it.
So he has a past history of alcohol challenges as well.
Yes. He definitely has a long history for certainly a 26-year-old of alcohol challenges. There have been more famously in the news, he was him and Tristan and his father were arrested for a domestic situation where the son was intoxicated and abusive to the father, and it became a physical altercation. This was a number of years earlier. I think when he was 18. But yeah, so there was a history of alcohol, but more importantly to the narrative is there was a 60-day hospitalization, which is significant. In our context, I think in Canada, we don't even keep you that long if we're changing your lung and your heart, usually in the hospital. So that's a long hospitalization.
Yeah, and in the States, whether it was a public or a private institution, they have very different kind of goals, and it's hard to know what it was that was
still serious. They say alcohol related, so.
Yeah, and the withdrawal piece itself, it's easier to sort of comment on that generally because some of the other symptoms could mean multiple different things there. So.
Of course. Okay. All right. Let's get to our clip number 2 here.
We both had decided that we were going to stop drinking. And so it was a situation where, we both went cold turkey. If you WebMD that, one of the things of cold turkey is that you have an increased rate of having, or increased risk of having a seizure.
So maybe that's what you sort of stopping there, right? Because that's what he's talking about when you stop cold turkey.
Yeah.
And I think some people when they read the WebMD or they talk to a doctor, they'll hear that don't stop suddenly, and then sometimes we see people like months later and they're still drinking the same amount, right? And because they're scared to stop suddenly.
Right, and it's tricky. I mean, we run into that with all substances, and opiate agonist therapy, of course, as well, where people are. The concept of tapering is not something that is well endorsed in the kind of. It seems to be in all substances a sign of weakness for some people. For whatever
that's interesting.
reason.
I didn't even think about that, but you're absolutely right. Like the more I think about it, people talk about going to detox and stopping everything all at once. People don't think about a gradual progression, and a lot of times people are so focused on the detox they put off improving their life until they get that part sorted out. I think we've heard a bit of the alcohol withdrawal stuff for this, right? And it's such a sad sort of a situation because how's an individual supposed to know that their specific situation makes them a higher risk, right? Because usually when you think about people that are like working and functioning and have jobs, you don't think about the alcohol withdrawal seizures. But even in a couple of things that we've talked about, right? Like in that other podcast where you shared about some family member, if that person were to stop, they could have a seizure, right? Mm-hmm. And so I think I think there's not enough awareness around this. And then the other part, I mean, it's with the other story that you told about their past, it's such a powerful thing that they're on the same page.
Yes.
Right? Like they're working together, they're on the same page, and such a horrible outcome that adds that other level of sadness, to what they've dealt with and gone through.
And I think the challenge for an addiction medicine provider is to come in and say, okay, well, you should do it this way or that way or this way. This is a hard thing to do, period. Right?
Yeah. And when you get that,
you got the motivation. They've decided on their plan. So who the hell are we to say, you know what, that plan, even though it's super important you stop drinking, we want you to do it a little bit in our way, not your way. And it's like, you know what?
Well, the thing is, do people even know about addiction medicine? Do they know they can go see an addiction doctor to do it, right? So now in Ontario, we have these rapid access addiction medicine clinics that are government funded. There's 20 or 30 in the province. I don't know, even in Toronto, right? Which I don't know how many people we have in Toronto. Do you have a few million? I don't know, a couple million.
We definitely do.
Yeah. And so there's like 7, 8, 10 clinics that are on like Monday to Friday within a 20-minute trip. You could find a drop-in clinic that'll coach you on how to cut back on your alcohol safely. They'll give you meds for the withdrawal, and they'll start you on an anti-craving medication.
Yes, 100%.
Right? And not every province, not every state has this, right? And if you go to an emergency department right now, they're just focused on the withdrawal. Is this guy going to have a seizure? They're not thinking, how do we get this guy out of this cycle of alcohol use safely, right? And, so I just think it's one of the things where people don't know where to go. And historically, even in primary care training, it's not there.
Right.
This is something that requires a medical. You can't toughen this out. You can't white knuckle it.
Right.
You can, but you're at risk of a seizure, and in this case, sadly, a heart attack. And I've had I think this is, I don't know if it's like a decade ago, how long ago it was, but you have people that have these other things where they'll fall, they'll smash their head, they'll have these small bleeds during the seizure, maybe they'll fracture a bone. Like, seizures are very, very unpredictable, right?
And the one thing that we're not talking about is that there are people that, there are prescribers and there are patients that will not manage those benzos properly because they may not stop drinking.
Yep.
And then there are prescribers that are fearful that they won't manage those benzos properly and they won't prescribe them. Yeah.
So when I started working in a rapid access clinic, maybe 10, 12 years ago, we had a drop clinic for alcohol use disorder. And that time, because when you're in the emerge, what are you worried about? You're worried about they have a seizure. When you're seeing somebody for 5-7 days, you're worried about the withdrawal symptoms on day 3, the withdrawal symptoms on day 7, the cravings on day 10. So all of a sudden that lens moves from that 1 to 2 days, like in that old figure, to that further time frame. And when I was talking to some colleagues about giving benzos, they're like, you can't, right? Because there's been cases where doctors give benzos, people drink, and then the doctor gets in trouble on top of it, right? And so it's almost like every time we try to correct for something that's clearly 100% wrong, there's always some kind of unintended consequence.
100%.
And doctors these days are very, very scared to give benzos. I don't want to go into too much of a tangent here, but nowadays, what's happening, at least in Ontario, there is a medication called Gabapentin.
Yes.
It's an anti-seizure medication also used for neuropathic pain. And there's very, 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 and I add that extra very because the data is becoming quite robust, that if you're somebody who drinks, and you're somebody that has alcohol withdrawal symptoms, right?
Yes.
It really helps in the early withdrawal phase, right? And so it helps with sleep, helps with shakes, helps with sweats. It doesn't really stop the seizure risk. That part is a little bit ambiguous, but for mild to moderate withdrawal, it's quite good. And people are quite a bit comfortable on it. And overall, if you stay on it, it can reduce your heavy drinking days over a month or two for it. And so now what certain addiction doctors or emergency doctors are doing, because they're so worried about the risk of giving diazepam or Valium, they'll just give Gabapentin. And there's a bunch of papers that suggest there's a very, very good signal for this.
Would Gabapentin have so it's iffy if whether or not it's going to reduce the seizure risk?
Theoretically, it reduces the seizure risk, but I don't think we can safely give it to prevent seizures. But in terms of the context of tapering the alcohol, right? So say if somebody's having a 12-pack a day, and they're going down to next week, they'll go to 10 drinks a day, then they'll go to 8 drinks a day, right? Like they'll do this slowly. The gabapentin helps with the sleep, right? So, so sometimes people drink in order to sleep, right? And when they stop drinking, they can't sleep, their thoughts race, they get anxious, they get a bit of tremors. And so it's really good for sleep and the tremors. And so what I'll do is I'll put a little bit of gabapentin on. I'll get them to track. I'll see them regularly, usually once a week, sometimes more, depending which clinic I work at, if it has that availability. So we have them taper down the alcohol, taper up the gabapentin, maybe add another med if they want, like naltrexone, and then taper off the gabapentin later.
Is the gabapentin, is that a U.S. name as well?
Yeah, it's a generic name. I don't know what the name brand is. It's been around for a long time.
Okay.
Mainly as a neuropathic pain med and as a not so great anti-seizure med, but it's very, very good for non-specific alcohol withdrawal symptoms. And the data is just coming out where it's, if you're somebody who drinks and you have withdrawal symptoms, it's very good in terms of relieving those symptoms as you cut back on your alcohol.
They're not in our clips, but there was a clip where Kevin spoke about different benzos. And I think he said that he is a Xanax guy and he made some disparaging remark about they gave his son Tristan clonazepam, which is I think he's something to the effect of a BS benzo or something to that effect. So, can you speak to that?
Absolutely, yeah. So around the 70s or 80s, I think like what happened in psychiatry when all these medications come out, first with the mood stabilizers, then with the antipsychotics, all of a sudden we had meds that can reduce people's symptoms, right?
Yeah.
And people got really, really excited about it, right? And then the 80s was the SSRIs and the antidepressants. And so 70s, 80s, 90s, we were using benzodiazepines that work on the same receptor as alcohol for symptoms of depression, but primarily anxiety. Now we know there's a lot of side effects with it. We've known it for a couple of decades, and there's a signal a little bit earlier, right? So when you're on these medications, you can have long-term memory deficits. You're more likely to have mild cognitive impairment when you're older. They don't work in the long term. So in the short term, they might relieve your anxiety. What happens? Your body gets used to it, right? And one of the best treatments for anxiety is learning to ride out those waves. Like if something crappy happens and then you feel that stress, then you ride it out, all of a sudden you're like, oh, I can get through this.
Right.
And then you start to be able to apply different skills for it as well. And I think that'd be fun to talk about how to work through it. The challenge with benzodiazepines, because they work on the same receptor, if the physician's not aware or if they're not in a proper treatment program, the withdrawal gets wicked, especially if you start drinking on top of it. And so it doesn't, remember that figure that I sort of alluded to?
Yes.
It doesn't always follow the same pattern. And so for alcohol withdrawal, we tend to use scales like the CIWA Scale, which CIWA, that gives you a score. And then based on the score, you give the medication. And we know that based on the symptoms, that if you give a certain amount, the person gets loaded. And then if you load them up a certain amount, they can self-taper off. But with benzodiazepines...
We'll put that CIWA in the description as well. We can do that.
Yeah, we can absolutely do that. It's publicly available. It's a bit dense, but basically it just gives you a score for your level of tremors, your level of anxiety, your level of sweating. It doesn't cover pulse and blood pressure because there's a lot of false positives for that. But it does give a good description around the alcohol withdrawal piece. With benzodiazepines, it doesn't follow the same timeline. It's sort of weird when the withdrawal symptoms come up and when they don't. And part of me wonders why the one case I was alluding to where they had seizures, but they didn't have the traditional withdrawal symptoms. Was it because there were benzos there? Was it because the person had some with them in their room? They were taking to cover some of the symptoms that were there, then the seizure occurred. And so when you're on Xanax, Clonazepam, Valium, Diazepam, I think Xanax is alprazolam, but we should check, right? They have different names in the States than they do here. What ends up happening is the withdrawal is not predictable.
Right.
And so the same way, if you're drinking a 2.6 a day and you go down to a Mickey or half a Mickey a day, you can have a seizure. If you're using 6 tablets of whatever benzodiazepine you're on and then you drop down to 2 a day after a month, you can have a seizure from that too.
Right.
And if you're on both and you drop down, it's hard to know what's what. And then even if the person was in the emerge taking these meds, they might not get the withdrawal fully covered. And so when I'm working with medical students, residents, and colleagues that are curious about this stuff, the thing that I talk about is that you really want to know what happens with GABA. You want to know what happens in the intoxication phase with the benzos and the alcohol. And you want to have an idea of the phenomenology of the timeline of the withdrawal. And you want to include it in your differential. And that way, if somebody's in hospital, someone's outside of hospital, if they're using benzos, if they're not, if they're mixing with alcohol, you just try to get the best history and figure out where they are in that withdrawal process. And then try to figure out with them when is the right time, the right way to taper down safely.
Okay. And so but to Kevin's point about the distinction between Xanax and Clonazepam.
Yeah, so this is where it gets tricky, right? Because I don't know what he was referring to.
Okay.
I don't know if he's referring to treatment of anxiety. I don't know if he's referring to
So he's been
withdrawal.
prescribed. He states in another episode where he's been on Xanax himself for 26 years.
Yeah.
For anxiety.
Yeah. So I think the challenge is then, if somebody's drinking and they have Xanax, the withdrawal is much different than if they just have alcohol withdrawal.
So,
and
this is one person's experience, and people have obviously everyone's got a different experience, but there isn't. I just don't want to lead people to a position to, as we've brought this up, that clonazepam is this horrendous medication and Xanax is a wonderful one.
No. So the relevance to alcohol withdrawal, right, is that you use the ones that have the longer half-life which would be clonazepam or diazepam, when you're treating alcohol withdrawal, and preferably diazepam. It just has more evidence. Clonazepam is not, it's not as good as diazepam for alcohol withdrawal. And if the person has liver function or liver dysfunction, then you'd use lorazepam, oxazepam, or temazepam. But usually the go-to is diazepam for alcohol withdrawal. If you're treating anxiety or panic attacks, it's a slightly different formula. And also the guidelines have changed dramatically over the last decade.
Okay.
Right. And so I hope that's clear. Clonazepam is not a crappy drug for everyone. Maybe it was a crappy drug in that situation. I can't comment on that. But I think it's important for the audience, well, especially healthcare providers, to know which drug is used for what, and what's involved in the withdrawal timeline and process.
Okay. And as you said, there's so many different factors involved that we just don't know, right? And even when you have the patient in front of you, you don't know whether it's the alcohol withdrawal, the like lowering the benzos, lowering the alcohol, combination of both, right?
Absolutely. And that's where the trust comes in. Because sometimes, when people are in withdrawal, they're anxious, they can't remember. But if you have that trust, eventually you can get a narrative of what they're actually drinking.
Yes.
And the first few weeks that I see people, even if I'm not giving meds, I just want to create a space so I know what's going in their system, right? Because as they're cutting back, they might have withdrawal symptoms. If the withdrawal symptoms stop, there was probably something the drug was doing to help them in the first place. And I want them to have a healthy way of working through that stuff.
So the key is to kind of have a good communication with a good relationship with your healthcare provider to navigate this path.
And the sad thing is, in this case here, it sounds like they developed very, very good communication. They just it was just the alcohol withdrawal risk wasn't so clear in
this case,
in
fairness, it sounds like their healthcare provider was WebMD.
Yeah, it wasn't a physician they talked to for the withdrawal process. But I don't know what state they live in. I don't know how accessible addiction medicine docs are.
No.
And historically, addiction medicine has mainly been doing opiate use disorder, and it's only the last decade that they've aggressively added alcohol.
Okay,
to it.
fair enough. So let's look at our last clip here.
Mm-hmm. And number one, our society makes alcohol very sexy. James Bond, shaken, not stirred. Women drink, champagne. And everything is so sexy.
So I don't know if it was like 5 years ago, 10 years ago, 15 years ago, I took some kind of a public health course where they talked about nicotine and the marketing for it. And these large companies knew right from the get-go what kind of marketing got what kind of response.
Yep.
They used to pay people to smoke in movies, right? You look at The Exorcist, they have a doctor's appointment with its child there, and the doctor is smoking a cigarette, the woman's smoking a cigarette. There's a good chance that these were paid advertisements. And then what ends up happening is that as these...
I never knew that. Really?
Yeah. So I don't know if it was paid advertisement. That part I
no, but that sort of thing could happen. Just like when you see in a movie they're drinking a can of Coke. Back in the day, they were paying for that. They're sponsoring
for cigarettes
sports
too,
events and everything else, like the Virginia Slims and the whole women's tennis movement being sponsored by a cigarette company.
Yeah, that's exactly it. And so what happened there is that there was a lot of signals that cigarettes were causing harm, but there was so much money being put into saying that, it's not causal. And it took about, 20, 30, 40 years before public health could say that, no, it is causal, and they had all these other regulations and rules. And every time there was any kind of regulation, right, whether it's like having the pictures taken away, having the pictures of the cancer of the lungs in the front, whether it's these e-cigarettes and the child flavors, the companies that were making money off it would fight tooth and nail to prevent it from happening. And then what would happen is that as these first world countries were having more regulation for smoking, these companies were making still tons of money. And how were they doing it? They'd go to the third world countries and do the same marketing stuff there. And then they'd get stuff in terms of the legal regulations. It was almost like this machine. And the same thing probably, and this is me assuming because I haven't seen the videos or read the papers, I assume the same thing happens with with alcohol as well. And now the harms are very, very clear. I'm a big fan of accurate risk. Yeah, all I'm saying is that, I think
well, we did a video recently on our Canadian
guidelines,
our new guidelines, talking about the new what they're defining as a safe guideline being 2 drinks a week, something to that effect, and that's something where we've navigated down from two drinks a day is the last published one, something like that, down to 2 drinks a week. So that's a pretty controversial thing. We've talked about how realistic that is for a lot of our people, and and that's
and for me, like I try to frame it under 2 different umbrellas, right? And so the 2 drinks a week is more around risks of various medical conditions. The other older guidelines, which was I think 15 a week for men and 10 a week for women, I felt, and I might be wrong, was more around the risk of developing an alcohol use disorder, right? And have like the risk of eventually getting withdrawal symptoms, stuff like that, or like unhealthy drinking. And I would hope that over time, society is aware of the risks. It's not my place to say that, you should drink or you shouldn't drink. And Kevin Nash is 100% right. What's Scotch? Scotch is a symbol of success. When you think about people in their 20s, bottle service, when you go to the clubs, it's a symbol of success. A glass of wine, it's how you enjoy your meal, right? Together. What do you do when you go on vacation? You go to an all-inclusive resort. That's your psychological break.
100%. And I mean, the sad part of it is for, he endorses it, his, hard drinking, hard partying kind of wrestling world that he glorified for his career, right? Is a part of it as well, right? That's what they did, right? That's the lifestyle that
you go to sports games, you're drinking your beers and stuff. So I think he's 100% right there, and I think public health has enough data to say what regulation is going to make drinking go up or down in which vulnerable population. And the challenge is that the companies that make money off this, I suspect, this is me assuming, are heavily involved in whether it's lobbying in the States or involved in the policy stuff here to try to prevent the use from going down.
Yeah. It's not far-fetched to think that these companies are have their kind of their survival as they're at their doorstep, right? So I think that's that would, if they didn't, you'd be shocked, right? If you
oh, fair enough. Yeah, if you're a business and you're trying to be successful as a business.
I mean, they're still selling cigarettes, right? There's still cigarette companies out there, right? Cigarette companies aren't trying to find ways to sell less cigarettes.
Yeah. And then when I was taking the course, they used to say things like they would change things like the concentration of this or the concentration of that, but then people would just adjust how much they puff, right, to still get the same nicotine hit and the carcinogen hit. But there were certain things that the cigarette companies would oppose like with such strength, and you knew if they were opposing it that this was the thing that's actually going to affect sales in the end.
Yeah.
And I think they're all guilty of it, right? Like when you think about marketing and the business, whether it's Facebook with how much screen time you have, or any of those tech companies,
sure,
or whether it's sugar and sugar versus fats, in terms of what causes heart disease, all that stuff is there. So
all right, so I think that. Anything else you wanted to add about?
Well, maybe I'll just sort of summarize what we've chatted about here, right?
Sounds good.
Just so it's sort of clarifies it sort of in my mind. There was this horrible situation that happened to this family where both of them were trying to do good, and the harms were directly related to alcohol use, primarily alcohol withdrawal. And today we tried to talk a bit about what makes somebody at risk for having withdrawal symptoms, some of the challenges that we go through in some of these non-medical or medical light or medical enhanced detox facilities in terms of covering those withdrawal symptoms. We covered a bit about the timeline of the symptoms, what occurs and when, a little bit about the treatment of it, but not a lot, but a little bit about the treatment of it. And most importantly, I think we really are pushing for increased public awareness about what the actual risks are, what makes somebody at risk, and how bad things can be in withdrawal. And hopefully, whatever region people are living in, they'll be able to find local resources to help them navigate this if it's something that they're going through, or a loved one or a friend or a patient is going through.
Absolutely. Okay. Well, thank you very much.
Okay, thank you.
All right, take care. thanks for watching. If you like what you saw, please feel free to like and subscribe. That way you'll get notified when we come out with new content. We try to come out with new content about every week or so. So anyway, thanks again and see you soon.